All right, let's dive right in. This is a high-yield board review of the 2023 European Insomnia Guideline. We're going to focus exclusively on the core diagnostic and treatment recommendations that you absolutely need to know for your exam. So here's how we're going to break this down. We've got 5 modules. We'll start with the official definition of chronic insomnia. Then we'll walk through the entire diagnostic workup. After that, we cover the non-negotiable first-line therapy. Module 4 gets into the second-line pharmacology options. And we'll wrap up with the treatments that are explicitly not recommended.
Okay, Module 1, Defining Chronic Insomnia. Look, before we can even talk about the treatment algorithm, we have to be crystal clear on the diagnosis. That means starting with the fundamental definition of the disorder itself.
So, what is chronic insomnia according to the ICD-11? It's not just trouble sleeping. It's very precise, and you need all 3 core elements. First, there's that frequent and persistent difficulty getting to sleep or staying asleep. Second, this has to be happening even when the person has plenty of opportunity to sleep. And third, this is critical, it has to cause some kind of daytime impairment. And don't forget the time criteria. This isn't a bad week of sleep. It has to happen several times a week for at least 3 months.
And to make that formal diagnosis, you've got this 2-part checklist. It's a 1 from column A, 1 from column B situation. The patient needs at least 1 nighttime symptom. You can see them on the left, things like trouble initiating, maintaining, or waking up too early. And they need at least 1 daytime symptom from the right, fatigue, brain fog, irritability. That link between the nighttime problem and the daytime consequence, that is an absolutely non-negotiable part of the diagnosis.
Now, to really get why the drugs we'll discuss later work, you've got to understand the 2 main biological systems at play here. First, you have the GABA-A receptor system. Think of this as the brain's primary braking system. It's inhibitory. The traditional hypnotics work by beefing up this system. The second target is the orexin system. This is the brain's wake-up promoter. The newest medications work by blocking this system. We're going to come back to this in Module 4, so keep these 2 pathways in mind.
Module 2, the diagnostic pathway. All right, now we're getting into the nitty-gritty. Let's examine the specific steps the guideline requires for a proper diagnostic evaluation.
So, the big question here is, what are the essential pieces of a thorough clinical workup for chronic insomnia? What do you actually have to do?
The guideline lays out a really structured approach. Your general anamnesis needs to be thorough, cover everything from medical issues to mental health, and really dig into substance use, especially alcohol and caffeine, and get a full med list. For the sleep history, you need the full story, when it started, how it's evolved, and here's a huge pearl for your boards, the guideline explicitly says to get information from a bed partner. You're hunting for clues of other sleep disorders like snoring, apneas, or limb movements. Finally, for tools, a sleep diary for 1 to 2 weeks is considered essential.
Okay, pay close attention here, because these are the kind of specific numbers that love to show up on exams. For the Insomnia Severity Index, the ISI, a score over 10 is your cutoff for a clinical case, and a change of 8.4 points is what you're looking for to call it moderate improvement. For the Pittsburgh Sleep Quality Index, or PSQI, a score greater than 5 means there's a clinically relevant sleep problem. You need to know these numbers cold.
This next point is absolutely crucial, and it's a common pitfall. The guideline is super clear. For the routine diagnosis of insomnia, you do not need actigraphy or polysomnography, okay? Neither is required. But, and this is the key part for your exam, you do need to know when PSG is indicated. The guideline gives you 3 specific scenarios. 1, you suspect another sleep disorder, like sleep apnea or periodic limb movement disorder. 2, the insomnia isn't responding to treatment. And 3, there's a huge gap between what the patient is telling you and what you're seeing objectively.
Module 3, First Line, the CBT-I mandate. I want you to pay close attention to the word mandate here, because the guideline establishes a very clear, non-negotiable hierarchy for treatment. Let's look at the absolute first-line recommendation.
And here it is, plain and simple. The first-line treatment is not a pill. It's cognitive behavioral therapy for insomnia, or CBT-I. This isn't just a suggestion. It's a strong recommendation. It's for all adults, and that explicitly includes patients who have other medical or mental health issues going on.
So what's actually in the CBT-I toolbox? Well, it's a multi-part therapy. It's got psychoeducation, sleep hygiene, relaxation techniques, and cognitive therapy. But here's the high-yield takeaway for you. The evidence cited in the guideline points to 2 components as being the real heavy hitters: sleep restriction therapy, or SRT, and stimulus control therapy, SCT. Those two seem to be the most powerful drivers of the positive results.
All right, Module 4, we're finally talking about medication. But notice where this falls in the guideline. It is strictly a second-line intervention. You only consider it when CBT-I isn't an option, the patient refuses it, or it just hasn't worked well enough.
The first class you need to know covers the classic players, benzodiazepines and the so-called Z drugs, or benzodiazepine receptor agonists. For the benzos, you've got lormetazepam, temazepam, and triazolone listed. For the BZRs, it's zaleplone, zolpidem, zopiclone, and ezopiclone. You'll want to be familiar with all these names. Now for the critical, board-relevant details on this class. Remember that GABA-A system? These drugs work by enhancing its inhibitory effects. The single most important point for prescribing is the duration. These are for short-term use only, and that's defined as 4 weeks or less. And you absolutely have to counsel patients on the key risks: tolerance, dependence, getting rebound insomnia when they stop, and next-day grogginess or cognitive issues. Long-term use? Generally not recommended.
Okay, now let's talk about the newest class of medication available for insomnia in Europe, the dual orexin receptor antagonists, or DORAs. The specific agent approved and listed in the guideline that you need to know is daridorexant.
And here's another specific detail right from the Phase 3 trials, the 50 milligram dose. That's the one cited in the guideline, and it's noted not just for improving sleep itself, but also for showing significant effects on daytime functioning, which is a huge deal.
So how does daridorexant work? It's a totally different mechanism. Remember the orexin system, the wake-up promoter? This drug blocks those receptors, which helps quiet down that wake drive. The duration is also a key differentiator. It's approved for up to 3 months of use, and there's data showing it works for up to a year. And here's a massive contrast with the BZRAs. There's no evidence of withdrawal or rebound insomnia when you stop it. Side effects are usually mild, things like a stuffy nose, headache, or some sleepiness.
We've talked about what to do, so now let's cover what not to do. This is your do not prescribe list. Antihistamines? Nope, not enough evidence they work, and people build tolerance fast. Antipsychotics for simple insomnia? No, lack of quality trials. Fast-release melatonin? Also no, due to lack of efficacy. And things like valerian root? The studies are just too weak to support a recommendation.
All right, our final module, Module 5, and this is just as important as everything else we've covered, knowing which treatments are explicitly not recommended. This is all about safe, evidence-based practice.
And just to really hammer this point home, especially for those common over-the-counter options, I'm going to read a direct quote from the guideline. It says, "The scientific evidence at this point does not support a recommendation for antihistaminergic drugs in the treatment of insomnia, either short or long-term." It really couldn't be any clearer.
So, we'll leave you with this final thought to reflect on. The entire point of this guideline is to establish a clear, evidence-based ladder of care. Given that CBT-I is mandated as the first-line treatment for every adult, the real question is, how does this challenge that common, almost reflexive, prescription-first mindset in clinical practice? This guideline is really pushing for a fundamental shift in how we think about and manage chronic insomnia.